Hello and thank you for joining us today. We continue to work diligently toward improving outcomes for women with advanced ovarian, fallopian tube, and peritoneal malignancies with the hope of earlier diagnosis, longer recurrence-free survival, improved patient-reported outcomes, what we call survivorship, and ultimately improving overall survival. In this OncLive peer exchange discussion on advanced ovarian cancer, entitled Optimizing Therapy Based on Current Data, my colleagues and I will provide a clinically relevant perspective on the most recent trial data, including the most recent information from the European Society of Medical Oncology 2018 annual meeting in Munich, Germany. My name is Brad Monk. I'm a professor of gynecologic oncology at the University of Arizona College of Medicine in Phoenix, Arizona, and Creighton University School of Medicine at St. Joseph's Hospital and Medical Center in Phoenix, Arizona. I'm also the medical director of the U.S. Oncology Research Program and also part of Arizona Oncology. Participating today are my two distinguished panelists, Dr. Michael Beer, Professor of Medicine of Hematology and Oncology, the Evelina B. Spencer Chair of Oncology and Director of the University of Alabama Comprehensive Cancer Center. Welcome, Mike. And also Dr. Ursula Machelonis, Chief of the Division of Gynecologic Oncology for the Susan F. Smith Center for Women's Cancers and Institute Physician and Professor of Medicine at Harvard Medical School in Boston, Massachusetts. Ursula, thank you.
It's great to be here, Brad. Thank you.
It's exciting.
It is.
It's been such a great ride since 2014 when targeted therapy really was launched in ovarian cancer. So we're going to talk today about ovarian cancer, epithelial cancers, fallopian tube, and peritoneal. And Michael, why don't you start off? So all of these patients need an operation. Tell us about, and I get it, you're not a surgeon, but I'm kind of a medical oncologist, so you're kind of a surgeon. So tell us about the staging and when the debulking happens in an ovarian cancer patient.
Well, as you said, I'm a medical oncologist. I could do the surgery, but it's not going to come out well. But even this area in ovarian cancer has changed,
Yes.
right? I mean, with now a number of randomized phase 3 trials, we know that neoadjuvant therapy is essentially equivalent to primary debulking. And that was a very large step forward. And so certainly our European colleagues adopted that, I think, initially faster than us. And in the States now, the pickup has been fairly rapid. Estimates between 40 to 60% of patients are now getting neoadjuvant therapy, meaning they get their chemo first, and then after 3 cycles, they get interval debulking. And I think part of what's driving that is that the surgery is a little bit easier. Yes. At least my colleagues tell me that after 3 cycles, resecting the tumor that's left is easier. From a scientific standpoint, frankly, we love it because we get tissue at the beginning of the diagnosis and we get tissue afterwards and we have matched pairs. That creates a lot of interesting science. So it's shifting, and it also raises up an interesting clinical issue, which is who do you triage for primary debulking versus...
Right. Yeah, I always say that's one of the hardest decisions we make, primary versus interval debulking. Clearly, neoadjuvant chemotherapy is the right treatment for a patient who cannot have complete resection, where there's cancer everywhere. And if you don't know who that is based on a CAT scan, physical examination, and so on, you stick the laparoscope in and try to figure it out. Ursula, in Boston, what percentage of patients start with chemotherapy or start with surgery?
So I think it's around probably between 50 to 60% will have, actually, let me try that again. So 40 to 50% will have upfront surgery, and the remainder, so it sort of it bridges that 50-50 range.
And our preference is primary debulking if you can do it.
Correct. That's
right. So the American Society of Clinical Oncology recommends that every patient be evaluated by a surgeon.
Correct.
And then once that decision is made, we can work together as a team. And medical oncologists, I have 2 on my right, one on my left, can take good care of ovarian cancer patients. So that's an exciting time.
I just want to make one comment about neoadjuvant chemotherapy, and something that I see come up not too infrequently is making that initial diagnosis.
Yes.
So you say putting the laparoscope in, sure, you're going to get tissue, a nice hunk of omental disease or a node. But for in the community, sometimes I still see diagnoses made by simple removal of ascites through a paracentesis. And there have been some good guidelines published now around the use, the appropriate use of neoadjuvant chemotherapy, where you really do need to make a tissue diagnosis based upon a biopsy.
A core biopsy.
A core
at least. Thank you
biopsy.
for that.
That's right.
Okay.
So you're not, because that cytology may come up just simply adenocarcinoma. It could be borderline tumor. It could be something else,
Right.
another primary tumor.